I too am very pleased to be here today. I'll have to confess I'm probably not quite as charismatic as Haywood Brown, who presented here last year, but I'll do my best. Let me say, before I get started, ACOG has over 58,000 members. If you counted our numbers right now, we're actually almost 63,000, but we had to say greater than 58. In this country, there are about 4 million births every year. OBGYNs do 85% of those. Certified nurse midwives do 7 to 8%, and family physicians do 7 to 8% of those. So it's really important that we're talking here from an obstetrical perspective. And I have to follow up because it was really timely when Dr. Rimley was talking about how AAP provides 16 weeks of parental leave. Literally this morning, we just decided to do the same thing. We have about 220 employees, 85% of which are women. So we're going to be providing 16 weeks of paid parental leave, and our short-term disability policy actually pays 60% of salary for 4 weeks for vaginal delivery and 6 weeks for a C-section. So literally, these people are going to have anywhere from 20 to 22 weeks paid parental leave. So I think that's really where we need to get to, and you heard that in several discussions. I have no disclosures to report today. I work for all the members of ACOG. I think we've all gone over the multitude of benefits of breastfeeding, and the evidence is so clear there. Obviously, the college strongly supports exclusive breastfeeding and recommends that it goes on for at least the first 6 months of life. And what I'm going to do today, I'm not going to read all the different bullet points, but I'm going to show you what we do to help our members and to help their patients as far as breastfeeding is concerned, and how we think that's so important. And it not only just goes to our members, but it goes to patients, it goes to hospitals, it goes to employers, all aimed at helping women breastfeed and take great care of their children. Well, we produce committee opinions. And I think Allison has been on some of our committees, and she's actually on our expert work group, which I'll get to in a little bit. And these committee opinions are members, anywhere from 8 to 15 members, and we have different liaisons. We have liaisons from the FDA, from the CDC, from the pediatricians, from the nurse midwives, and they work to come up with these documents. And then from that point, they're further reviewed by a clinical document review group, and then they go to our executive board. The bottom line, the point of this is by the time one of our documents is blessed and goes out to publication, close to 100 OBGYNs have reviewed it, edited it, and make sure it was accurate before we send it out. And so what I'm going to run over with you is the current committee opinions that relate to breastfeeding and how they're helping our members, how this one talks about what our role is in supporting breastfeeding, the importance of educating people around it during prenatal care, how you really help the dyad, the mom and baby, and making sure that our members know about the resources that are in the community. We have Committee Opinion 570 identifies the unique barriers. This comes from our Underserved Women's Committee. The unique barriers that these people have on the initiation and continuation of breastfeeding, and how we really need a multidisciplinary approach involving practitioners, family members, child care providers, and other folks in the community to help these women overcome the obstacles and achieve their breastfeeding goals. Committee Opinion 711, talk about opioids. Lord knows we have an opioid crisis in this country. But the big take-home message for this is that women who want to breastfeed, who have a history of opioid use, but who are now stable on opioid agonist therapy and not using illicit drugs and not HIV positive, should be encouraged to breastfeed. And so this really gives our members the ammunition and the information to make sure that they can educate their patients about, who have these issues, about how they can still breastfeed. Now, Allison alluded to this a little bit before. Committee Opinion 736, which is the new, and Haywood mentioned it last year, about the new paradigm for the fourth trimester, the postpartum period. Okay, I told Allison I was going to say this. I told somebody I was going to say this. Where was the first postpartum visit described? It's in the book of Luke. It's Mary returns to the temple at 42 days to be cleansed. 42 days just happens to be 6 weeks. We started there, and it's been 6 weeks ever since. That's just not logical. You know, we're moving to a 2 to 3 week initial visit, postpartum visit, and then serial follow-up visits. This committee opinion really introduces the 4th trimester, and that term is catching on in the literature. We think it's really important. And so it really redefines our role in helping women breastfeed, screening for postpartum depression. I'll tell you, my younger daughter had a serious postpartum, a suicidal level postpartum depression. She didn't commit suicide, but she almost did once. So I've lived that too. You know, you talk about personal stories. It's amazing, and anything we can do to identify that and manage that and refer and take care of those women is crucial. But I think one of the huge parts about this 4th trimester is recognizing 2 things. One is that pregnancy is a window into women's health. You know, the people who deliver preterm, the people who have preeclampsia, the people who have gestational diabetes, those women with preeclampsia have a higher incidence of heart disease. Those women with gestational diabetes have a 50% chance of becoming an adult onset diabetic later in life. So we have to take that information and use it going forward. So it really gives us this opportunity to take the postpartum visit and making a transition into ongoing women's health care. And I don't think it's ever been really looked at like that. So I think that's really great and very important. What about marijuana? You know, it's the next cash crop, right, going on all around the country. And Lord knows a lot of women are using it, and we felt we had to address it. And it includes, this committee opinion 722 does include guidance on marijuana use in pregnancy and in lactation. But the problem is we just don't have much data on it yet. So we end up having to say there's insufficient data to evaluate the effects on marijuana use on infants during lactation and breastfeeding. And so without data, we discourage it, which is obviously the right thing to do. Eventually, maybe we'll get the data that we need. Doing that controlled study, however, might be somewhat difficult. As you can tell, we have a lot of documents. Our committees work really, really hard. 723, and I think this is a huge one. Guidelines for diagnostic imaging during pregnancy and lactation. How many of you have heard about the 32 or 35-year-old woman who's breastfeeding, who has a lump, and it's just a galactocele or it's just a cyst, and 6 months later, no, it really was a cancer. And we all have this paranoia about imaging pregnant women and imaging breastfeeding women, and that's just wrong. And that's what this document really says. You know, ultrasound and magnetic resonance imaging are perfectly safe in pregnancy and perfectly safe for lactating women. But you don't use them willy-nilly. You use them when they need to be used. But the other thing that's important, with very, very few exceptions, X-rays evaluation, CAT scans, mini nuclear medicine tests, the radiation exposure for mom and or fetus or breastfeeding baby is so low, it's really perfectly safe. So you don't deny appropriate imaging tests to women who are pregnant or breastfeeding because they're pregnant or breastfeeding. And the other little take-home tidbit is in MRIs, they oftentimes will use a gadolinium to enhance them, and it's fine to breastfeed after a gadolinium-enhanced MRI. Okay, postpartum pain management. You know, obviously, this is right in the wheelhouse. Here we've got these women, they've just delivered, either vaginally or C-section. They're uncomfortable. How are you going to manage them? How you make them comfortable? And how you can do that in a way that facilitates and doesn't cause any issues around breastfeeding. You know, my numbers said 81% of women initiate breastfeeding initially in the postpartum period. Somebody had 83% on a slide earlier. You know, the U.S. Food and Drug Administration has come out with some recommendations around opioids in breastfeeding, and I'll talk about that a little bit more in just a second. But pediatrics, AAP has a great little list that shows, Advil or Motrin, ibuprofen is level 1, it's perfectly fine. Toradol, which is actually level 2, which is also fine. But naproxen or Relieve, Anaprox, it's sort of level 3 and sort of moderately safe in breastfeeding. What the FDA came out with in April of last year was a warning about codeine and Ultram or tramadol. Tramadol is an opioid-like compound. Somewhere between 1 and 10% of all of us have ultra rapid metabolization that goes on in the liver of codeine and some opioids. And what that does is if I take a Tylenol number 3, I'll gradually build up a level of codeine. But for these folks, it shoots up very high very rapidly. And if they're breastfeeding and they breastfeed right after they've taken this medication, their babies can get a higher dose of a narcotic, which is worrisome. And so people have to be carefully counseled if they're using codeine, and they're really probably better off to avoid that or Ultram if at all possible. So that's all in this committee opinion to help our members. We have a breastfeeding handbook that we put out. We do this jointly with pediatrics. You heard how much AAP works with CDC. Well, AAP works about the same with ACOG. And ACOG and CDC work about the same. It's a real great triangle, actually. We just put out our second edition. It gives guidance for physicians, really for all specialties. And the revised edition includes new information on the benefits of breast milk to preterm infants and breastfeeding and how to handle breastfeeding during a natural disaster. Whether some of the issues that were going on in Puerto Rico are really what was going on in Haiti, how to deal with all that. And it's my understanding is that the incidence of necrotizing enterocolitis in the NICU is much lower where babies can get breast milk than otherwise. We have now in our 8th edition of Guidelines for Perinatal Care, which we also do with pediatrics. We do these every 5 years, so we've been doing this for 40 years, putting this information out. This maintains focus on reproductive awareness and regional-based perinatal care services, which add a focus on patient safety and quality improvement. And this edition actually talks about maternal transport and actually even talks about planned home birth. And also, obviously, it deals with immunization, nutrition, and breastfeeding. But we want to make sure that there are lots of information out there. Our expert work group on breastfeeding created our breastfeeding toolkit. And it was developed to increase breastfeeding rates by enhancing the provider and patient knowledge on obviously breastfeeding benefits. And it was developed by the work group with funding from the W.K. Kellogg Foundation. I think, Laura, you just mentioned you work with Kellogg, so thank you for that. And it was to enhance provider and patient knowledge on the benefits of breastfeeding using the latest information, materials, and resources. So just another modality out there, and that picture is actually one of the slides from the toolkit. The toolkit contains the early committee opinion, which I talked about, but it also gives a physician conversation guide, how to tee up the discussion about breastfeeding with your patient. Somebody mentioned earlier about coding. It has a series of codes, how to code for breastfeeding issues so you can get reimbursed. It has a FAQ, or frequently asked questions, that can be given to patients. It's got a breastfeeding infographic. And we have a patient education manual or pamphlet called Breastfeeding Your Baby, which can be given out. And then we give a list to the providers of all the resources that we have and others have out there. The breastfeeding information for patients, I mentioned, the Breastfeeding Your Baby FAQ. This is just an example of what that is. A list of frequently asked questions with the answers. So it's a quick resource for patients. we've had for a long time what we call our baby book. This has been out for 30 years. We do things every 5 years, except for the committee opinions. Those are updated every 18 months to 2 years. But the big books are every 5 years. And in this, we put our guidelines, and they're written by experts. We do it jointly. Once again, AAP participates in this. And it gives the patients the most accurate information available about pregnancy, childbirth, labor and delivery, breastfeeding, and the postpartum period. So just another example of how we're educating our patients to help them feel better about their care. This is a great resource. Anybody who knows somebody that's about to have their first baby, it's You and Your Baby, Prenatal Care, Labor and Delivery, and Postpartum Care booklet. It's an ideal resource because it really explains the components of prenatal care, provides information on what to look for, what are problem signs, and then what happens in labor and delivery, what happens in the postpartum period, and of course it stresses the importance of breastfeeding. But we work with lots of other folks. Obviously, we work with the Academy of Breastfeeding Medicine, and otherwise I probably wouldn't be standing up here today. We work with the United States Breastfeeding Committee. Obviously, we work with AAP. We work with NICHD and the 1,000 Days Initiative. I know somebody's here with the 1,000 Days Initiative, so we have worked well with them. Let me tell you a little bit about the Breastfeeding Expert Work Group. You know, I've shown you that we have a lot of materials and we've done a lot of creation to get information out there. But this is such an important issue to us, we created a special task force or work group. Allison is on it. And we did it 4 years ago in February. The group serves as an advisory group to the Committee on Obstetric Practice. It's comprised of general OBGYNs, maternal fetal medicine specialists, and we have OBGYN lactation consultants on there. They also have liaisons there from the United States Breastfeeding Committee, the Academy of Breastfeeding Medicine, Baby Friendly USA, and AAP. So it's a well-resourced group. They work to develop accurate content in patient and provider resources and continue to demonstrate ACOG's commitment to help women achieve their goals for the best care possible. We also link back to WHO and UNICEF with their Baby Friendly initiative, and we help stimulate and motivate facilities to do that. We have endorsed the 10-step process, which y'all have already looked at today, and we support the World Health Organization calling on all facilities to try to identify and utilize the 10 steps. But they do more than that. Every year they'll have 2 or 3 topics that they'll put on at our annual meeting. They'll usually clinical seminars. They also will do a 3-hour postgraduate course at our annual meeting on breastfeeding. Allison probably knows this. We actually have an e-module. It's in development. You're the first people to know that we actually have that in development. But I said, I can tell them that. That's okay. It's not out yet, but it's coming. We have a member that sits on the Breastfeeding USA board. Obviously, we endorse the 10 steps. We edit documents. Anytime a document's coming around, that many of those committee opinions that have a focus on breastfeeding, it goes to this work group to be reviewed and evaluated and improved. And most importantly, it has a legislative advocacy arm. There are 2 current bills that we have been working for. One is the Friendly Airports for Mothers, or FAM Act, which I think Karen showed a picture of that. Senator Tammy Duckworth, who's a Democrat from Illinois, and Representative Stephen Knight, who's a Republican from California, are the co-sponsors of that legislation. And so we are supporting and pushing and hoping to make that happen. I will tell you, we just had an interesting and sad event. After our annual meeting in Austin, one of our members who was breastfeeding, who had several small containers of 2 or 3 ounces of breast milk, tried to get through TSA security. And it was very awkward, and they felt they were not treated appropriately or professionally. And we're actually sending a letter to TSA about that. The other act or bill is supporting working moms, which takes where the ACA is to another step. And this is put forth by Senator Jeff Merkley, who's a Democrat from Oregon, and Representative Carolyn Maloney, who's a Democrat from New York. It really is to ensure that all working moms will have the right to breastfeed, and extending that federal law to ensure that executive and administrative and professional employees, including school teachers, have the right to a reasonable break time in a private, non-bathroom place to express breast milk at work. Well, as I'm winding down here, I want to stress that we recognize as obstetrician gynecologists that our role is to assist all women, to help them stay healthy, to help them through their pregnancy, to help them have a healthy baby, and to motivate them and assist them initiating breastfeeding. At the same time, as has been said a couple times today, we recognize that some women will not be, they just, for whatever reason, they'll be, whether it's a medical, whether it's medication, whatever, there will be some women who won't be able to breastfeed. And one of the dangers, as somebody who's delivered 6,000 kids and taken care of a lot of women for 30 years in Western North Carolina, you don't want to make them feel guilty. You know, breastfeeding is wonderful, and we really have to be motivators and supporters and encouragers. But when somebody can't do it, we also have to support them and make sure they feel appreciated and understood, because it doesn't do anybody any good to feel that you're a, quote, failure because I can't do this or do that. So, in total summary, ACOG supports, obviously strongly supports breastfeeding. We obviously recognize the value for patients and infants. We developed the multiple resources which I've shared with you, and you can always go to our website at www.acog.org and look about breastfeeding or breastfeeding resources. And I've got that, but I have to tell you, I really made a boo-boo. And you can't see this, but I'm going to show Dr. Lawrence this. This is my then 3-year-old granddaughter in Seattle, and she's now 5. She had her new baby brother, and so my daughter Megan was breastfeeding Henry, and that's Vivian doing her own modeling with her T-shirt pulled up and her doll on her chest. And I really should have had that as a slide, and I apologize for that. But you know, that's good. You know, that's they see that as normal, and that is very, very good. And so, that's what should be up there right now. That's my bad. So, that concludes my remarks. I'll be glad to try to take any questions. Thank you. Any questions? Okay. Oh, wait a minute. From the back of the room?
Just a quick comment, a thank you, and a question. ACOG's committee opinion a number of years ago, maybe as many as 15 now, around HIV testing and prenatal care was hugely impactful. I think at the time we were at an incidence of 300.
Right.
Most recent estimates put that at closer to 40 now,
Right.
Which is fantastic. The question is, would ACOG maybe perhaps consider re-looking at breastfeeding among women with HIV, given all that we know now about undetectable being untransmittable?
You know, we re-look at all those issues on an every 18-month, 2-year basis. And I think we would obviously be willing to relook at that. That's something that we would want to do jointly with AAP. And we have liaison from AAP on our OB practice committee and on our breastfeeding expert work group. So, I mean, I think that's something that we could discuss, because, you know, the antiviral therapies and everything have changed this so dramatically. I mean, we all lived through that. When you got HIV, you died. And now it's a chronic disease, and most people with it will die from something else. So I don't know the science around that enough to other than what I just said, but I think it's obviously something we would be willing to look at.
Hi.
Yes, ma'am.
Do you have enough questions on your certifying board to make residents really interested in learning about breastfeeding and supporting mothers?
Okay, well, good question. The ACOG does not certify. Yeah, the American Board of Obstetrics does that. But through CREOG, our Residency Education and Obstetrics and Gynecology Council, we have a curriculum, and breastfeeding is a significant part of that curriculum. I was the board examiner for like 17 years, one of those mean, hateful people that asked all those hard questions. And there, from time to time, there would be breastfeeding questions, oftentimes that would come up around infectious disease. And the other things that would come up were about complications, breast abscesses, how you deal with a really cracked or bleeding nipple and those sorts of things. But the education side of it is clearly laid out in our educational objectives. Does that answer your question? Right.
Is our prenatal component from obstetrics, and it's something that all baby-friendly efforts across the country have faced.
Right.
That is their biggest challenge, is getting the prenatal component done and getting the obstetricians engaged. So I'm just wondering if you have any ideas about maybe bringing them to the table.
Well, I can't tell you I have a specific idea on how to do that, but I could tell you, obviously, from everything I've said, everything we have done, we are totally supportive of the baby-friendly concept and doing what needs to be done to make that happen. I suspect the solution to that is on a hospital-by-hospital basis, with champions from the pediatric side working with champions on the obstetrical side to make sure that the right things get done. Yes.
Balaji from the neonatologist in Jackson, Mississippi. That's a perfect segue into my question. And it's the same concern with the baby-friendly, but more towards the education aspect. The AAP also has a curriculum on breastfeeding. But as you know, the new generation residents and ACGME, to be precise, if it's not on the ACGME plan for them, they don't want to know about it. What are we as pediatricians and obstetricians working with ABP and ABMS doing to work with ACGME to make that not mandated, but sort of a requirement?
Well, I think actually in the milestones for OBGYN residency education, I worked on the residency review committee a long time ago for 6 years or so. But in the milestones, I think that talks about education for breastfeeding. That's part of what they're supposed to know. And I do know that on some of the in-training exams, the CITROG or our in-training exam, there are questions around breastfeeding to try to validate that. I mean, I think it takes a local, you can say what you're supposed to do, but it takes somebody holding them to the task and rightly or wrongly asking them questions about it. Oh, I just saw Mrs. Jones. She had a baby at 38 weeks. She's doing great. She's going to go home today. This is her second child. She didn't. Did she breastfeed her first child? No, she didn't. Is she going to breastfeed this child? Why not? It takes a little bit of guidance on our part to make that a reality.
That's what we've done in Mississippi. But when we were introducing the curriculum, the prevailing comment was, well, it's just 1 or 2 questions. I really don't need to know about this.
But it's how you take good care of your patients.
So thank you so much. I've been so proud to be part of ACOG and be involved in these different efforts, and I've so appreciated ACOG's enthusiasm for this topic. I think one of the places we can really help, and in the blur of people, I now can't remember who made the point about the challenges that young women face as doctors in training and young physicians trying to breastfeed their own children,
Right.
is to make sure that we continue to do things like having the pumping space at our national meetings, making sure that infants in arms are welcome at any event geared toward trainees unless it's dangerous. Like, I'm not suggesting you scrub a section with a baby in a sling, but really working to make it possible, because
Right.
what I see in some of the attendings who are a generation older than me is their own still present anger 20 years on about their terrible breastfeeding experience that translates into saying, this is stupid, you don't need to know about it. And so we have a real opportunity
It's a culture change.
by making sure that the generation, the 88% women who are going through residency training, are able to be capable OBGYNs and moms at the same time. So I think we just need to really work on that.
I totally agree with you. You know, I think it takes leadership. You know, and people have to have the resources like you talked about, and people have to be supported and not blamed. You know, this is heaven knows we're OBGYNs. You know, if we can't be supportive of breastfeeding moms, what's going on? You know.
Amen.
Hi, I'm Grace Damio. I'm from the Hispanic Health Council in Connecticut. Just a comment about resident education. Our peer counseling program integrates into prenatal clinic, into postpartum, post-labor and delivery, and into community and homes. And one of the things we deliberately do is have them sit and meet with residents on a regular basis. They know more than the residents know. They get to know the residents. They become part of the team. And they've actually had an impact on hospital practice overall. But one of the impacts is having residents get to know the importance of breastfeeding through them. So that's one strategy that has been really useful.
Yeah, let me ask a question. This just popped in my head. How many of you have any centering of prenatal care? Because I think that is an ideal area to pull a resident into a centering session and a lactation consultant into a centering session and let people talk about initiation and maintaining breastfeeding. I mean, it's just, and everybody learns. The patients learn, the residents learn. I mean, it's a good vehicle to do that. Okay. Well, thank you all very much.